Welcome to Module 17, Health Policy. I'm Professor Donna Groulet. Today we'll review the policy process in the United States. Irving Zola, a medical sociologist and advocate for disability rights, is credited for the Upstream Parable, which goes like this. There I am, standing by the shore of a swiftly flowing river, and I hear the cry of a drowning man. I jump into the river, put my arms around him, pull him to shore, and apply CPR. Just when he begins to breathe, there is another cry for help. So I jump into the river, reach him, pull him to shore, apply CPR, and just as he begins to breathe, another cry for help. So back in the river I go, reaching, pulling, applying, breathing, and then another yell. Again and again, without end, goes the sequence. I am so busy jumping in, pulling them to shore, applying CPR, that I have no time to see who is upstream pushing them all in. This parable is used as a metaphor for our current sick model U.S. healthcare system and the need for upstream preventive approaches to health. This is public health. But in order to change a sick healthcare model into a well healthcare model, we need different policies and advocacy for these improvements to be realized. Within the United States, as well as other countries, the policy process is driven by a problem. For example, in the late 1980s, used needles and other medical wastes were washing up on beaches in New York and New Jersey, posing a health threat to beachgoers. This was definitely a problem, right? What happened next was the federal government, specifically the US EPA, drafted an interim policy on medical waste management. It was implemented in 4 states and Puerto Rico for 2 years, then evaluated to determine its effectiveness. This is an example of how the policy process works. Policy is made at the federal, state, and local, county and city levels, and follows a similar process. This graphic depicts a similar policy process, except that it applies the previous principles to the political process. Discussion and debate occur assumedly over the issue or problem. Next is the political action that is proposed, then incorporated into draft legislation. Once these are passed by a legislative body, a law or policy is established. Laws are usually very general but hold power in the penalties assigned to them. Back in the 1980s, environmental policy had strict penalties, some up to $25,000 per day, for violating hazardous waste disposal policy. These policies identified regulatory agencies who were empowered to develop corresponding regulations, which were very specific and described how to implement the policy. Using hazardous waste policy as an example, California's Health and Safety Code, where state environmental law is found, identified Cal EPA as the regulatory authority to develop regulations and enforce them. Well, that brings us to compliance, which is a form of evaluation of the policy through inspections, citations, and penalties based on the original policy. Keep in mind that the regulations hold limited power, but the policy carries penalties, such as fines and/or incarceration for non-compliance. Let me give you an example of how policy is drafted in our state. In 2006, California passed Assembly Bill 32, the California Global Warming Solutions Act, which is represented by the purple box labeled legislation. However, to get to this point, a lot of work went into developing this policy. First, an issue had to be identified, and it had to be serious enough to warrant either a change to an existing policy or a completely new policy. In this case, a variety of conferences took place with presentations from scientific experts, and I personally attended a few of these, that showed the relationship between vehicle emissions, greenhouse gases, and climate change. With this evidence, and public health is part of this group of experts, policy was starting to be drafted in the form of unofficial documents, such as green and white papers. However, policy can't be drafted in a vacuum. It needs input from the public, usually from stakeholder groups. As you can see from this graphic, public comment intersects this policy process several times. Not only is a draft released, but public comment sessions are held so that the public has an opportunity to submit written and verbal comments, either in support of or in opposition to the draft policy. Public comments for this specific policy were assimilated and changes were made to the document that was sent back out for public comment after significant revision. Keep in mind that for each comment, the regulatory agency proposing the policy, in this situation, the California Air Resources Board, or CARB, must capture and address each comment, identifying if the comment was substantial or not. Then the agency, CARB, submits its final proposal for approval. Both at the state and federal levels, this draft policy needs a sponsor, an elected official, to take this forward and shepherd it through the approval process and lobby for its support. For AB 32, this was Assemblyman Fabian Nunez, and his name is printed on the policy. After the policy was approved, it was signed into law by the governor or the president for federal policies. Then regulations must be drafted by CARB on how to enforce this policy. Once these are approved, the policy must be introduced to those who will be impacted by it, such as businesses, citizens, and governments, and they must be educated about what they need to do to comply with this new law. As the policy is implemented, reporting must routinely occur to a governmental oversight agency on the effectiveness of the policy. Here's a list of influencers of public policy in the US and other democratic countries. There's a lot of things to consider when proposing and implementing policy. Take a minute to think, which of these items happen behind the scenes and which happen in the public's view? How much transparency is needed for effective policy development and implementation? Often it feels like policy is made without our knowledge, let alone our input. How can we as public health professionals influence policy development? In the US, we have an initiative called Health in All Policies, or HIAP. This started in 2006 in Finland and has spread across the globe as a policy strategy. It has 3 fundamentals: integrate health across sectors, collaborate to achieve goals, and benefit all people, not just certain groups. An example of how California has implemented health in all policies is the Department of Public Health and the Governor's Office of Planning and Research have partnered to expand the availability of affordable, locally grown produce through land use strategies. These 2 agencies collaborated for the good of Californians to tackle the problem of obesity by using policy, land use choices, to increase access to healthy foods. This graphic models how a variety of factors are used to shape policy, including certain health issues, determinants and inequities, how policy and those who have a stake in a health issue play a supporting role. Then data, listed at the bottom, plays a big part in evaluating policy options. The best options are then selected and trialed, with case studies brought forward as examples. My previous example of the Medical Waste Tracking Act was trialed for 2 years, with data being used to evaluate the policy options that were implemented before taking this into a national policy. Health in All Policies is designed to touch all areas of influence that intersect with people, including disparities, food, housing, jobs, recreation, and safety. This graphic from the Bay Area Regional Health Inequities Initiative depicts how health and associated inequities intersect all areas of our society. From upstream social, institutional, and living conditions on the left, to downstream behaviors, diseases, and injuries, and ultimately death depicted on the right. Notice how policy, circled in red at the bottom, weaves through all areas, while advocacy is applied to institutions to leverage change through research, community partnerships, and policy development. Now let's switch gears and look at policy evaluation. In the healthcare and safety fields, we've implemented a system of determining the cause of an issue through root cause analysis. Essentially, this strategy answers why until the root cause of the problem is identified. Here is a simple fishbone diagram of why a family fought during their vacation, and I'm sure this may even have happened to you. The problem, fought too much, is listed on the left, with 2 corresponding layers of reasons in orange. Each of these layers answers the question why until the root cause is uncovered. Then in green, some suggestions are listed to correct the problem the next time, or maybe even avoid it. In safety, root cause analysis is used to determine why an employee accident or injury occurred in the workplace. In healthcare, root cause analysis is used to uncover why a patient was adversely affected during their hospital stay. This includes things like patient falls, adverse drug reactions, and unintended deaths. These investigations are illustrated using this type of fishbone chart. Categories of causes are listed, such as people, environment, or equipment, with the parallel lines to the main problem being the primary causes. The secondary causes are listed off of the primary cause. Let's say that a patient at risk for falling actually fell during their hospital stay and was injured. These events are required to be reported to the California Department of Public Health, who regulates all healthcare organizations in our state, and a root cause analysis of the event must be submitted. So the problem would be the patient fall, right? As we conducted our investigation, we found that the healthcare worker assisting the patient from the wheelchair to a gurney did not have an assistant present. That would be a people cause. But why wasn't an assistant present? We found the policy was in place that required 2 people to transfer a high-risk patient. After interviewing the employee, we found that he was unaware of the policy, a primary cause. But why? We reviewed the onboarding process and found that employees weren't trained on this policy, a secondary cause. So we've updated the orientation process for all new employees to include the procedure of patient transfer and lifting, requiring 2 healthcare workers to be present for high-risk patients. Going through this process can help you to understand how to improve policy. Going back to our Upstream Parable, As professionals in public health, we must understand the policy process and how we can influence the output for the benefit of all. This actually may require us to walk upstream to see who's pushing everyone into the water. Thank you.